Welcome to the Wild and Fierce podcast. We are your hosts, Amber
and Johanna. We're here to explore womanhood through real, raw, and unfiltered conversations.
Please remember this podcast is for education only and not a substitute for medical advice. Always consult your own healthcare professional.
Let's dive in.
All right, everyone. Welcome back to another episode of the Wild and Fierce podcast in season 2. I'm super excited for today, Johanna, as well, because we are bringing one of our very good friends and expert in all things hypermobility, Taylor.
Hello. I'm so excited.
Hello. Happy you're here. So, Taylor, I'm not going to steal your thunder. I want you to explain what you do, who you are. Tell us a little about your story. How did you get into hypermobility? All the fun things.
Sounds good. All right. So, hi, I'm Taylor. I'm a chiropractor by trade, but I now call myself a virtual hypermobility coach. We're going to learn a lot about what hypermobility means, but I basically work with a very specific condition called Hypermobile Ehlers-Danlos Syndrome, as well as hypermobile spectrum disorder. We're going to learn about both of those. And the reason I got into this is because I live with this myself, and I realized that a lot of people are dealing with this and feel very helpless and hopeless that there's anything they can do to help themselves. And I have found a lot of ways to help myself that I tried on other people, and the rest was kind of history. So I get to help people get stronger, help people understand their body better, and help them feel more hopeful about their condition and their life and living the life they want.
Okay, how did you figure out later in life you had hypermobility? Did you find out as a kid? Like, can you tell us if someone's listening and they're like, how would I even know? Like, what? Take us back into history.
Yeah, so my story is not the usual. I have a very unique story where I found out when I was very little. I was actually in second grade because my mom went on her own journey and then saw some symptoms in me and got me help from a very, very young age, which I do think has set me up for success later on in life. And I really want to see more of that. And as advocacy is getting better, as we're learning more, that's happening more and more. And so my story is not the usual. Usually there's actually a paper that just came out. It's 22 years until you're diagnosed with this condition. And that's a big problem. And we need to change that. And so most people have no idea that they're living with this, have no idea this exists. And that includes clinicians, that includes doctors. And the biggest reason for that is the education system. We had literally 2 PowerPoint slides about EDS in chiro school. I will give my chiro school some credit because they have reached out to me and now they have a full lecture on this, which is awesome. And more schools need to start doing that. Yeah, which is still not enough.
That's still not enough.
But it's
better than nothing.
Slides. It's better than the 2 slides. It's baby steps. But yeah, and I've talked to multiple different healthcare professionals, medical doctors, physical therapists, and across the board, we are not learning enough about this condition, period.
Yeah. Okay, what is hypermobility for anyone listening? Okay. There's no clue what that even is. Break it down for us.
So we're going to get into a bunch of words, so bear with me. So hypermobility, there's 4 types. What being hypermobile means is that something in your body goes past the desired end range. Think of if you've ever been told you were double jointed or you've ever seen somebody that's quote unquote double jointed, that means you're hypermobile. Double jointed is not a real thing. You don't have 2 joints. You just have extra bendy joints.
Okay, I've always been curious about that. And like, I have an exercise background and I've always been like, what is up with the double jointed terminology? Like,
is it just a stupid word someone came up with?
It's literally, I actually don't know the history of it. I should look into that, but it is literally not a real thing. Like, by definition, double jointed would mean you have more than 1 joint. And that's not what we're saying when somebody is double jointed. So it's literally just a misnomer. But yeah, I'm curious about the history of that. I honestly don't know.
That's so funny. Yeah, it's a very weird thing. I've always thought, I'm like, they don't have 2 knees, they don't have 2 elbows, 2 shoulders.
Right.
Like,
yeah, I don't know where that word came from, but
but I've totally said it before.
Oh yeah, 100%.
Totally said it.
Called it my whole life.
Yeah,
my whole life, and then I learned later, oh, that's not a real thing. So there's 4 types of hypermobility. There is peripheral hypermobility, which means just in your hands and your feet. Localized, which means just one area, so just your shoulder is hypermobile. There's historical, which means you were hypermobile in the past, but you no longer are. Mm-hmm. And then there's generalized joint hypermobility, which means 5 or more of your joints in your body go past their end range. That's the one we're going to be talking about for the rest of this conversation. That's the one that is going to lead to some of the other things that we're talking about today. Not that the other three aren't important. They are. It's just not what we're going to be talking about today. And so when it comes to generalized joint hypermobility, again, meaning 5 or more of your joints go past their end range, that splits off into 2 categories, asymptomatic and symptomatic. It is important to note that you can be super, super bendy and have no symptoms. This is the Simone Biles of the world. This is the amazing athletes that get to use their mobility to their advantage. In a recent paper that just came out, and this is something that we've been hypothesizing for years, it is now more and more confirmed that asymptomatic can turn symptomatic via very specific things. And those 3 things are some sort of trauma. This can be emotional or physical trauma, viruses like mono and COVID, and postpartum pregnancy. And so if you are asymptomatic and you know you're hypermobile, doesn't mean we need to freak out. But if we happen to get one of those 3 triggers, we want to be prepared that, okay, what can I do proactively and what can I do reactively if I do become symptomatic? Now, in the symptomatic category, that splits off into genetic and acquired. Acquired means you got it from a sport like gymnastics, cheerleading, dance, or trauma like a car accident can make you acquire hypermobility. And then on the genetic side is what we call genetic connective tissue disorders. There's literally so many of these, but the one we're talking about today is something called Ehlers-Danlos Syndrome. There's, as of right now, 14 types of Ehlers-Danlos Syndrome.
Holy cow.
Yeah, the one.
I didn't know that.
Yeah, and the one we're talking about today is called Hypermobile Ehlers-Danlos Syndrome. This is the most common type, and it is also the only type that doesn't have a genetic code, meaning it is diagnosed clinically. And so, yeah, what questions do you have from that?
That's wild. I didn't know
Amber's
it was
She's like,
It's-
holy cow.
well, like we're saying off camera, I'm like, there's such a spectrum
Yes.
to hypermobility, and I think that's why it's so misunderstood and why so many people do go undiagnosed for so long, because it's so, I don't know if broad's the right word, but there's so many different variations, and if you're not educated in it or you didn't have a family member or someone that was aware of it, no wonder people go undiagnosed for so long, or they're just called double jointed. Like they have no idea.
Yeah, and the reason it's so complex and it is a spectrum is because it's a genetic connective tissue disorder, and connective tissue lines literally everything in your body, your muscles, your organs. It's what your ligaments are made of, literally everything. And so it can be affecting every single system in your body. And we're getting more and more data showing that because of this, it also comes with a lot of what we call comorbidities. And there are some common ones we can talk about as well. And those all have their own subsets of differing symptoms. So this is a spectrum disorder. You can be on one end of the spectrum or the other. And either end, if you are struggling, you still deserve help. The one thing that I see a lot in my clients is, I'm not as bad as so-and-so, so I don't need help. And that's just not true. Just because you're not as bad as so-and-so doesn't mean that you're not struggling. You still deserve help and deserve to live the life that you want.
Can we go into symptoms? Does that feel like an appropriate time for this? I feel like we
Can I ask a quick question?
Yes,
real
go
quick?
ahead.
So the acquired hypermobility, you had mentioned trauma, and then what was the other?
Sports.
Sports. Have you also seen that with mold? Because I know that people that have had mold exposure, which is a way higher percentage than I think because mold is also really hard to diagnose and catch because it presents so differently across different bodies, that it can affect joints as well. And I think that was part of what was going on for me, is I was like fine for so long. I don't think we've talked about on the podcast, but I'm hypermobile. And I worked with Taylor and it was awesome. But I was going along until I was 17, had a knee injury, had mono, life kind of like took a turn at that point, and then had mold exposure. And I feel like that's when like things started getting like really intense. So I'd be curious what your thoughts are of like almost like illness, but in like environmental exposure of things, or like if heavy metals are connected, or if there's anything like that too.
So we don't have data on this. So this
Okay.
is what I'm about to say is anecdotal, but I would put that in if you're thinking of a graph, the asymptomatic to symptomatic, those 3 things, I would be putting environmental factors on that side of it,
Okay.
Whereas when we're saying acquired, what we're really meaning is like you actually acquired the increase in range of motion through
it.
something.
Got
Like
it.
you got in a car accident, you got whiplash, and
You're
now your
close.
ligaments have more range of motion, or you
Okay.
were doing oversplits in gymnastics, and now you're dealing with more range of motion in your ligaments because of that, in comparison to you had a predisposition to this and you've been asymptomatic, and now you had a trigger of some sort that made you symptomatic. That would be under the genetic category, not the acquired category.
I see.
Does
Okay.
that make sense?
Yeah, that does. And then the other question I had was about the historical, because I just found that really, really interesting. So they were previously hypermobile and now they're no longer. Would that be that they are no longer symptomatic and like presenting, or like literally those joints are no longer going past range of motion? And then what typically causes that?
Literally, their joints are no longer going past that
Okay.
range of motion. And usually this is an age thing. And so
Right.
there is a theory that there is a kind of theme we go through in this. And the last theme is stiffness. And so it's usually, in my opinion, a kind of domino effect more than a true physiological
Okay.
effect. And what I've really seen in the historical category is that because of your hypermobility, you didn't know how to manage it. We got really afraid of movement. We stopped moving. We stopped doing any sort of real exercise or range of motion, and now we lost it because of that. So that's usually more so what I personally see in that realm. That being said, there are some other things that can bring on historical hypermobility. And there also is, like, you can get labeled historical in that category, even if you are hypermobile right now, meaning though that like you don't want to go through that range of motion because it's going to harm you. And so you don't want to go through the testing for generalized joint hypermobility. And so that's more of a like labels game than anything else, which I don't really like to play. If you need help, let's just help you, whether you have a label or not.
Yeah, for sure. And I think that's why I love your approach and like your community so much is you don't need to be diagnosed to get help. And I think that's the frustrating part of being hypermobile, trying to seek help, and you're like told, well, yeah, you're like maybe you're mobile, but you're not diagnosable or whatever it may be. And it's like, but that doesn't mean that I'm not struggling. And I think we see that across all different health aspects, right? Like PCOS goes undiagnosed, thyroid issues, Hashimoto's, all these things. And just because someone doesn't meet criteria doesn't mean that they don't deserve help. And I think that's like the most unfortunate side about the like, oh, what's the word? Almost like standardization of our medical community is like because they have to standardize it to keep things consistent, which I get. So many people fall in the gray area. It actually makes me kind of think of functional lab testing versus diagnostic lab
It's like
testing.
read my brain.
Yeah, like standard lab testing. It's like
Yeah.
because they have to have regular blood panels, and we're going to do an episode on this for anyone that's like super curious about it. But the standard like providers in conventional testing, it basically like you have to be so extreme so they can then diagnose you, then treat you, right? So then give you meds, surgery, whatever it may be. But what if you're like really severe and your life is like significantly affected, but you're not as extreme as what they have deemed diagnosable, and then you just completely fall through the cracks. You're in that gray area. And I think that's like 99% of people that are struggling, which is just so sad.
And
And it's like I get the standardization, but it's also like we also only have one life, right? And I think people deserve so much better.
100%. And I think there's two sides of that too. I think there's the medical side of it, the clinician side of it, where if you see something and you can help that thing, whether they have a label or not, you have a due diligence to do that. And I don't understand professionals who don't.
Yeah.
So that's the first thing. And then the second on the kind of medical side is we don't need labels to
Yes.
for everything. I think there's a part of this that we're over labeling a lot of the
Yeah.
time. And then there's a part where we're under labeling. And so in the hypermobile space, getting a diagnosis can be a really challenging thing. And there are pros and cons to getting diagnosed. And the reality is, it's a clinical diagnosis. We don't know for certain if that really is what you're dealing with because it's a clinical diagnosis. And the diagnostic criteria is so outdated. It's from 2017. They are working on redoing it, but it is so specific. If you don't meet the exact specificity of it, you're just thrown to the wolves, and it shouldn't be that way. And so let's talk through the diagnostic stuff, and
Yeah.
some of the symptoms will come in with that. So
Perfect.
the first part of the diagnostic process is, are you dealing with generalized joint hypermobility? Do you have 5 or more joints in your body that go past their end range? The most common scale to test this is something called the Baton scale. The Baton scale is a great quick first screening tool. It tests only 9 joints. And the problem is a lot of clinicians stop there. If you don't pass that, you don't have generalized joint hypermobility, call it a day. I'm not saying we need to throw the Baton scale away. I think it's a great, quick first screening tool, but that's exactly what it should be. If your patient passes it, great. You get to move on a lot quicker than the person that does it. But if the person in front of you is presenting with the symptoms of this disorder and they do not pass the Baton scale, do not stop there. There are so many other scales that you can use. The 5PQ would be my next one, and the lower limb assessment scale, and then the upper, well, oh man, I'm blanking out on the word. There's another one for the upper extremities. But think through this logically. That test only tests 9 joints. It also only tests, like, out of those 9, 4 of them are your fingers. So it's really just seeing, like, are your fingers hypermobile? Doesn't test your shoulders, doesn't test your hips, which are the 2 most common areas that are hypermobile in people. Doesn't test your spine at all either. So there's like a lot of things it doesn't test. And so if any clinicians are watching this, if you're going to take away anything from this, do not stop at the Baton scale. There is a lot more that you can do to figure out if the person in front of you is dealing with generalized joint hypermobility. And any clinician can do that. Physical therapist, chiropractor, occupational therapist, MDs, DOs, across the board, that is all within our scope, and we should all be able to see if somebody in front of us has more end range or not, period. So that's the first step of the diagnostic process. The second is a list of systemic symptoms that commonly come along with hEDS. And honestly, the list is not what we are now deeming the common symptoms, but we'll talk more about that. So the list, it has 12 symptoms. You need 5 of them to meet the criteria. And then the other half is, are you in chronic pain, which is the #1 most common symptom in this population is chronic pain. And are you dealing with any sort of joint subluxations, true medical subluxations, not chiropractic subluxations. A true medical subluxation is when your joint partially comes out and then comes back in. Or are you dealing with any dislocations where your joint fully comes out and never comes back in? Those are the 2 most common symptoms in this population. And then after that is where physical therapists, occupational therapists, chiropractors kind of have to outsource for a formal diagnosis. So we're able to fill out that first part and that second part. But the third part, you need to go to a geneticist. In the States, I know rheumatologists in other countries are the ones who does it, but let's just talk the States for the sake of this conversation. And then a geneticist would run something called a connective tissue panel to make sure that you're not dealing with any of the other types of EDS, as well as any other connective tissue disorders that might mimic this condition.
That is a blood test.
It is a blood test, yeah. That is the full diagnostic process, which, as you can see, can take a lot of time, can take a lot of money because a lot of insurances aren't going to cover this. And so it's not always the best route for some people sometimes. Now, if you meet criteria 1, but you don't meet criteria 2, the systemic questions, that's when you get diagnosed with something called hypermobile spectrum disorder. From a clinical standpoint, they're the same thing. One is not more severe than another. We don't really know much about the differences right now. And so for the sake of this conversation, think of them as the same, except that the person who got diagnosed, make sure that they feel validated with that label, because a lot of people will be like, oh, I wasn't diagnosed with EDS, so I'm not that bad. I'm not that severe. I don't need as much help. Have that conversation with the person in front of you, because that's not true.
Can you break down a little more of the systemic stuff that they might feel?
Yeah, so the common ones are the ones that are on the sheet.
Okay. What do you see most commonly? How about that?
Okay, so most commonly systemically, GI system is the first one to be affected. And what we usually see is IBS-like symptoms. So a mixture of constipation, diarrhea, as well as inability to digest. So there's something called gastroparesis that's really, really common in this population. And then reflux or heartburn is really, really common in this population as well. And so GI is usually, I don't think I have a single client that doesn't have some level of GI something. Second would be anything in the autonomic nervous system dysfunction family. So something called dysautonomia is very, very common, and symptoms of that could be a racing heart. Can also be feeling dizzy, but not like vertigo dizziness, more like you feel like a staticky radio in your head and you get stars when you stand up, fainting, feeling like you're gonna faint, feeling really, really thirsty, feeling like you never take in enough water can also be a part of that. Shortness of breath can be a part of that. Something called blood pooling can be a part of that as well. And then we're talking systemic. So headaches in general, migraine, very, very common. There are some very serious neurological disorders that can also come along with this, including upper cervical instability, as well as CSF leaks. So chiropractors, be very careful, especially if you're considering adjusting this population. Maybe think twice before you do that. And then pelvic floor is a huge component. Prolapse is actually on the diagnostic checklist. That is very, very common. Incontinence is very, very, very common. And so is just pain with intercourse in general. And then systemically cyclical related symptoms we see very, very commonly in this population. Eyesight can be affected, having a higher frequency of things like retinal detachment, etc. I think that is a lot, but those are some of
We
is-
haven't
it is
asked it
fun.
yet, and I think it's important to know, especially for people that are just learning about this and curious if they have it or not. It is not progressive.
Correct. It is not a progressive disorder. So, what a progressive disorder means is that the disorder by nature gets worse on its own. For example, Alzheimer's. Alzheimer's gets worse no matter what you do.
Mhm.
This is not a progressive disorder. What that means is it will not get worse on its own, but if we don't manage it, the
Mhm.
domino effect can make your symptoms worse, but it
Yeah.
is not making your connective tissue worse. But
Would
your
agree.
symptoms can become worse, and that's what we want to get in front of. But it is so important to know that this is not a progressive condition.
Yeah. Super interesting. So I'm currently pregnant, and one of the like hypermobility things in pregnancy that I found really interesting is your uterus is more stretchy.
You're the second person that has told me.
Yeah, so the baby sits low. So I'm carrying high, but then the baby's really low. So the baby has like been on top of my cervix since like 18 weeks, which is like fine, and I'm used to it now, but it's something that like I didn't expect. But I was like out for dinner one night, and there was like the super woo-woo gal that does craniosacral, and she's like, "Oh, can I feel your tummy?" And so she felt it, and she's like, "Well, it's sitting really low, and it's kind of hot, so I think it's a boy." But then I'm like carrying really, really high, and so that made me really curious. I'm like, "How can you carry so high, but then the baby is so low?" Like it feels like sometimes the baby is about to come out. And I looked into it, and it's connected to hypermobility, which I think is really interesting. Like we will talk a little bit about birth and pregnancy, but there's a lot with that too.
Yeah.
That's really interesting. And then I also think that postpartum affecting or like triggering hypermobility is also very, very interesting.
Yeah. The postpartum piece, I was shocked when I first started this. The
Yeah.
number one thing I was seeing was fine your whole life, fine during pregnancy, postpartum symptoms, feeling like you've never been in this body before.
Yeah.
And that is the number one thing that I saw when I first got into this. This was kind of before COVID. And so then now I'm seeing equal amounts COVID doing that and
Yeah.
postpartum doing that.
Yeah.
So it is interesting.
And I could see like EBV and mono. Like
Yeah,
that's also in my and I feel like
now that's documented for the first time ever, which is
yay, cool.
yeah.
Well,
Yeah.
especially because I feel like, at least what I see in my practice, is COVID often triggers similar symptoms to EBV and mono for people that had an issue with EBV and mono. So it's just interesting that that's all kind of connected as well.
Yeah, 100%. And so, do you want to get into the birth stuff now?
No, I want to touch on, because now that I'm like understand hypermobility, I've worked with you, which I also am gonna like plug. I worked with Taylor for 7 months before I got pregnant. highly recommend. Like if you think you're hypermobile and haven't had babies yet, or maybe you have had babies, but you're either postpartum or you're thinking about having another baby, like taking some time and understanding hypermobility and getting strong. Like my pregnancy, it didn't go like as smooth. Like I remember you saying like, oh, a lot of my hypermobile clients feel great during pregnancy. I
Yeah.
felt actually a lot of hypermobility more in pregnancy, especially with my hips. And so I feel like that kind of like rocked my world a little bit. But having strength trained and gotten so much stronger and understanding my body prior to this, like absolute game changer. I can't imagine what it would have been like had I gotten pregnant prior to doing that. And then now I'm working with Amber during pregnancy to continue with the strength. And honestly, I feel like I haven't even like been able to do as much as I wanted to, but I still feel very strong and I still feel very great core connection and stuff like that. So plug for both of you ladies, but I highly recommend. I like constantly am just like I'm so happy I did that prior to getting pregnant because I like just don't even like feel the weight of my belly a lot of the time, which is pretty cool. But as you learn about hypermobility, I feel like you then start picking it out, and everyone in your life, wait, like I think you're hypermobile and you're hypermobile. But the response that I get from a lot of people is, but I'm really stiff or I'm not flexible. Can you talk about, I want to cover both of those. Like flexibility is not mobility,
Yep.
and stiffness, in my case, was a consequence of hypermobility. So that's why I kept not getting diagnosed. And I still don't have like an official diagnosis. I don't really care to have one. But can you talk about that? Because I think that's like why so many people don't get caught in the system
Yep.
because it's like people just think really stretchy skin and really bendy joints where that's not necessarily the case.
Correct. So flexibility is not the same thing as mobility. Flexibility is your muscles' ability to go through a full end range or not. Whereas mobility is your joints' ability to go through a full end range or not. There is a huge difference between muscles and joints being able to do this. And an example would be my elbow bends backwards. My elbow is hypermobile, but I'm trying to think of like a flexible arm trick, and I can't think of one right now, but I'll use hips instead. So if I was able to bring my foot behind my head, that would be hypermobility in my hips. Whereas doing the splits is going to be flexibility in your hamstrings and in your hip flexors, etc. So that's the biggest difference is they're just literally not the same. And you could be very hypermobile and have no flexibility at all. Now, as far as the stiffness conversation goes, there is a real reason for that. When you have a genetic connective tissue disorder, your ligaments are made up of connective tissue. In normal people, their ligaments bounce back and they provide stability for everybody. When you have loosey-goosey ligaments, it's like an overstretched rubber band. It doesn't bounce back. And so that ligament can't do its job. It can't provide the stability that it needs to keep your body functioning and safe. Our body is really smart. It tries to help us out. And so it says, okay, she has no stability there. I'm going to get really, really tight to provide that stability for her to keep her alive and to keep her functioning. And so that tightness then can make you feel really, really stiff, which is the number one most common thing that I hear. You'll also hear you have the tightest muscles in the world from your massage therapists. And what I want you to know about tightness is it's not good or bad. It is neutral. Tightness is there a lot of the time to protect you. And in this case, it is doing just that. Now, when that tightness becomes too much and your body can't handle it, it might bring on symptoms, and there are things that we can do to make the muscle capacity higher so that that tightness doesn't affect us symptomatically more and more over time. And that means that we have to create that strength and safety within the whole system, which is why strength training is so important in this population.
So if someone is, sorry, go ahead, Johanna.
And that population's told to not strength train.
Correct.
Go ahead, Amber.
So if someone's really stiff, is it a lot harder for them to get a diagnosis? Because will they still have, like, will they feel double jointed or extra bendy if they're really stiff? They wouldn't, right?
Depends on the area. And so, but yes, that's a huge reason why people don't get diagnosed.
Yeah.
Honestly, though, most practitioners don't even go past the bait and scale anyway, so I don't even know if that's the real reason, but that's a perceived reason from many of my clients is my doctors didn't think I was bendy enough for this condition.
Yeah.
The reality, I don't think doctors are actually looking at enough joints to really tell if somebody is bendy or not bendy, but that feeling is, I feel so stiff. How on earth could I be hypermobile?
Yeah.
That makes
Well, and I
sense.
think that the biggest like aha moment for me is it doesn't have to be all joints that are hypermobile too, or some joints might be stiff and some joints might be hypermobile, but that doesn't mean that you're not hypermobile. And like for me, my ribs are super stiff. Like my range of motion to rotate is very, very tight, but that's my fascia and my muscles trying to give my body stability to give me support, right? But my shoulders, my hips, my knees, my ankles are very, very mobile, which then probably makes my torso try to compensate even more. But I think that's why I was misdiagnosed or not caught for so long because, well, my ribs aren't extra mobile. So then I'm not hypermobile, you know?
Yeah.
So, and I think that's how a lot of people feel. So for the flexibility and mobility, it kind of seems like mobility is range of motion, flexibility is muscles' ability to stretch. However, people that are more mobile are also likely more flexible because their muscles potentially allow for more range of motion. But just because you're not flexible or you're stiff doesn't mean you're not hypermobile. And I think that's like the biggest thing that's really hard to grasp because our society talks about mobility and flexibility as the same. And like when you talk to someone about it and they're like, oh, I have chronic pain in all of my joints. And I'm like, go talk to Taylor, you might be hypermobile. They're like, but I'm really stiff.
Yeah. Yeah, you
It's
nailed it.
really interesting.
100% agree. Yeah, it's honestly more of a like humans can't comprehend that two things could be true at the same time.
Yes.
Like
Yeah.
you can be hypermobile
Yeah.
and really, really stiff and really unflexible, which it is a weird thing when you think about it. So I understand
is.
why they feel that way,
Super
but
weird.
it
Yeah.
is the reality.
Yeah.
But
Super
it
weird.
makes sense if you break it down as like muscle and ligament and then joint. And I
Correct.
think that's what I don't think a lot of people know.
Yeah.
Yeah.
They've just kind of bunched it all together
Yeah.
and assume you're mobile and flexible at the same time versus like, no, they're two separate things.
If you're doing everything right, but still feel exhausted by 3 p.m., can't lose those stubborn 10 pounds, and your periods feel like a monthly battle, this isn't your fault. Here's what's really happening. Most women are following advice designed for men's bodies. We're told to cut carbs, try intermittent fasting, just eat less, and move more. But our metabolism works completely differently than males' metabolisms. Your body isn't being broken, it just has bad advice that's not actually geared towards you. When you're exhausted, moody, and your hormones feel chaotic, your body is actually trying to communicate with you. It's saying, I need support and not restriction. This is why we created the free masterclass, Women's Metabolism and Hormones Made Simple. In just about an hour, give or take, we'd like to talk, you'll finally understand why your body feels like it's working against you and exactly how to work with it instead. You'll learn about the truth about women's metabolism, how much food you actually need to support your hormones, and why weight loss is so much more complicated than calories in, calories out, especially for women. It is completely free and you can watch it anytime that works for you. This is such pivotal and important information that we wanted to make it super accessible. So you can either visit the show notes in this episode or head to wildmusewellness.com, go to resources and products, and you'll find the masterclass there. Stop fighting your body and start understanding it.
Yeah, and bringing up like mobility and flexibility in general, like society has this idea that like more mobility is always better, more mobility
Yes.
is always
Yeah.
better. Do this for more mobility. And if you're hypermobile and you're not realizing that and you're just like constantly trying to make yourself more mobile and you keep running into the same thing over and over again, you probably should change up what you're doing, because when we are in this population, we don't need to be doing more mobility drills. We need to learn to control our range of motion and we need to get really strong.
Yeah, that's super interesting. The last thing that kind of comes to mind on this topic is the first person that actually pointed out to me was a pelvic floor PT, and she was moving through, she did a full body assessment, which was really cool rather than just pelvic floor. But she said, your joints don't give me any resistance or they don't have any tension to them. So they're kind of floppy. So when she moved my shoulder, she's like, there's no tension against me moving your shoulder. It's very loose. I do have like a strong amount of range, or like a hypermobile amount of range, but I think a lot of women also already have that. So is that something that you also see and maybe could encourage providers to look at, is like the tension or the feel of the joint? It's not even necessarily the range of motion at the same time.
Yeah, 100%. And like that is how we're supposed to actually
Yeah, okay.
figure out how somebody's, if they're going past end range or not. Just not a lot of providers do it, but yeah, 100%. That is what your joints are going to feel like if they are an overstretched rubber band. They don't have the ability to do that. What you'll also hear is like having very, very tight muscles in very specific areas. A lot of the time, the upper traps are super, super, super tight. And again, that doesn't have to be a bad thing. And so when your massage therapist tells you you're the tightest in the world, just nod and say okay and move on with your day, because it doesn't have to be this negative thing. We just need to learn, okay, what are my upper traps asking from me? Maybe I need to strengthen my rhomboids and my lats so that they don't have to work so hard. Maybe I need to create safety in my neck so that they don't have to work so hard, et cetera, et cetera.
Yeah, we're massage therapy, and that's where some people might get a little bit of relief temporarily because they got some blood flow to that muscle.
Yeah.
But it's not going to affect anything long term because it's much more of, it's a deeper issue at hand. And I feel like that's something I try to explain to a lot of people is massage, yoga, stretching. Yes, they have their place, but if they're not giving you long lasting relief, it's because there's something deeper going on.
Yeah, absolutely. And I'm of the opinion that anything in the passive modality family, would it be massages, chiropractic adjustments, dry needling, anything in the passive modality family should be used for short-term relief. And there is a lot of value in that. Being able to give that to yourself is very, very valuable, but that cannot be the only thing that you do. And it cannot be, the narrative around it cannot be that this passive modality is going to fix you or is going to long-term create a change in your physical body, because it's just not able to do that. It's just not.
Yeah. Everybody just hit rewind right now and go back to what she just did, because that is so important and not enough people talk about it. Because I can't tell you how many times we hear, oh, well, this modality fixed me. Well, chiropractic keeps me going. Like dry needling, whatever you want to pitch in there, massage, you name it. Again, they have a place, but if you have to continuously keep going back all of the time, it's not fixing you. It's a Band-Aid that you have to keep reapplying. It's like when your Band-Aids get wet in the shower.
Yeah.
You gotta take it off and reapply it. Like,
and guess what? You don't need to be fixed. You're not a car. You're not broken. You're a human being.
Exactly.
And you get to, I hate this whole you're healed. Like healing is a journey that you get to do for the rest of your existence. And that comes with exploring different modalities and learning about your body through that. That doesn't come with this one quick fix is gonna heal me. Humans are way too complex for that. It just doesn't work like that.
100%.
We all want it to, though. So
so bad. So bad. I think if we could just find a way to not want that, I don't know how to do that yet.
I know.
Our problems would go away.
The wellness industry needs to stop marketing so well. That's how we start. Yeah. We stop with all the dang greens powders and detox teas. Just like Amber was talking about.
I've made so many
weighted vests.
Oh, yes.
It's the new one now.
Oh, weighted vests are huge. Or I also feel like creatine right now is like all the rage. And I'm like, sure. Like I get so many clients that are like, what are your thoughts? And I'm like, I'm sure it might be helpful to some people. Is it going to solve all of your issues? Probably not.
There's nothing that's going to solve all of your issues. I will say though, creatine can be a good addition because it is going to, they have shown recently, it can be cognitively helpful. Later on in life. So I am a fan of creatine, but again, it's not going to solve all your problems.
No, it's not going to, It's not gonna.
It's all the marketing that makes it seem like if you do this one thing. I just made a reel on this the other day. There was this account, huge account, posted this reel that said if you do this one movement, it will heal your pelvic floor, stop your leaking, snatch your weight, like this whole list of things. And there was literally thousands and thousands and thousands of people that had liked it, saved it, all these comments. And I was like, this is the problem. This is why so many people, men and women, are so defeated and struggling and so frustrated because we're sold that one thing is going to fix everything. And again, we're not a problem that needs fixing.
Exactly. And there's so much more to every single thing that helps people. Like when people say chiropractic is the one thing, like That's great, but you're making it seem like it was the adjustment when in reality it was the contextual factors. It was your practitioner that you trust telling you this is going to help
Yeah.
you. It was the environment that you put yourself in and you paid money to be helped and you want that to help you. That's also part of it helping you. Like there's so many contextual factors that go into these things that none of us put any emphasis on. And so if it seems too good to be true, it 100% is. It just
Yes.
is.
I think
Yeah.
that's the great way to look at things right there.
Yeah. And I feel like it's hard because we live, I always call it like our Amazon, like instant
Mhm.
gratification society. And it's like we want that one day shipping, you know, like we talk about this on our podcast. We want our births to be easy. We want our podcast to be easy. Podcasts are
That
easy.
too.
We want our postpartum to be easy. We want breastfeeding to be easy. I think building a business, like we're three entrepreneurs, it's not effing easy. It
No.
is so hard. And I think so many people quit at the first sign of struggle because they want it to be easy. And I think it's just a really interesting day and age. Like we're very fortunate, very lucky. I feel like we're very privileged for
Yeah.
all these opportunities and stuff that we have right now. But a lot of people in our society are so hung up with this quick fix, instant gratification must be easy, or otherwise, if it's too hard, it's not worth it, or it's not working, or something like that. And it's just like all three of us work on foundations with people because foundations are actually what works, but they're not sexy. And it's just
Mhm.
that's like a whole nother conversation that we like we could really dive
Yeah.
into.
And like tying it into the hypermobile space, the hypermobile space is a very vulnerable space.
Yeah.
It is a spectrum, like I said, and there are some people who are bedbound. There are people who are truly, truly disabled from this condition,
Yeah.
and they are getting fed the same level of marketing as we all are. And when you're in that state, you want to be
Yeah.
helped so bad that when something is promising you what you've been searching for, of course you're going to want to take it. And then
Totally.
you do, and you're either in the same place or worse. And now you spent money and time, and then you just get more hopeless and hopeless and hopeless. And it is our job to, like, our job as in clinicians to not perpetuate that more and
Yeah.
more and to start having these real conversations on social media. It is a mess on there right now. Like, I have never in my life been so honestly disgusted every time I go on Instagram, but we have to keep doing it because if we don't, they win and we can't let
Yeah.
them win.
Yeah, for sure. Well, I think the hard part about I think with hypermobility or just like any like chronic illness, chronic disease, or even someone that's experienced a chronic symptom for a very long time, every time you try something that gives you a promise, like whether it's, you know, greens powder for your bloat or whatever it might be, and then it fails, that just like adds to the narrative that you are unique and you're broken and nothing can help you. And then that keeps you mentally stuck there. And I think that was my big issue with a lot of my gut issues for so long, is I tried all of these things and nothing would work. So I just like, well, I guess I'm gonna have candida overgrowth and, you know, gut issues for the rest of my life. Like nothing can fix me. But it's because I wasn't doing the right things because those right things aren't sexy and they're not marketed, right? And I'm sure it happens, and know it happens with pregnancy and
Oh
postpartum
yeah.
hypermobility too. And it's just, it's so sad because it's like, it's really preying on vulnerable populations. And it just like really makes you question like the morality of everyone out there. It's like, holy smokes.
Yeah.
It's sad.
It's a big problem. And it's, I would say, and I'm biased and I'm in a bubble, but I would say it's even a bigger problem in the chronic illness space,
Yeah.
Oh
Oh, for
yeah.
sure.
especially in the hypermobile space around movement. There
Yeah.
is so much gatekeeping. Don't
Mhm.
strength train, do low weight, do Pilates. That's the only thing that you can do. You can't run, you can't.
Yeah.
And you're putting people's lives into smaller and smaller boxes when they don't need to be, and you're harming them by doing that. And so if you've ever been told that and you are hypermobile, I want you to know that you can do all the things. It's not going to happen quickly. It's not going to happen easily. It takes a lot of work and a lot of time and the right approach. But there is, in my opinion, there's never the word no when it comes to moving your body for 80% of people in this space. There are some comorbidities that there are things that are just going to be no. Like if you have upper cervical instability, we're not going on roller coasters. We're just not.
Mhm.
But there's for the most part, we can make things happen in our body. It's just going to take a lot longer than I think people like to admit or realize. And you're going to have to go a lot slower than you're used to or that you want to. And you're going to have to experience some symptoms along the way. I think that's something we don't talk about enough. We think that, okay, I'm in physical therapy, I'm working with a coach, I'm going to be pain free. Like, no, part of this is learning how to deal with pain because pain is a part of life. We want to be able to do more with the same level of pain. And that's just as much of a progress measurement as how is our pain decreasing, etc. Being flare free is not a real thing, especially in this community. And so our goal with our clients is decreasing the intensity and frequency of that. And I think that needs to be talked about more.
I think about this with like my own prolapse journey. Like, you hear all the time, cure your prolapse, get rid of every single symptom. And so then clients will come to me and ask me questions like that. And they're like, so you're totally asymptomatic all the time, right? And I'm like, no, I'm not. Like, do I still pee myself as bad as I did then? No, absolutely not. Do I still cry with my poop? No. Is sex still terrible? No. Like, I have made massive, massive progress, but I have triggers. My period is one of them. Every time I get my period, I get pelvic heaviness. I know it to the T every day of my first period. I know that certain bladder irritants will make it more likely for me to leak. If I have bad pressure management, like any diagnosis, just like life in general, you're gonna have symptoms for things. There is no like on off switch. Okay, you're cured. All your symptoms are gone. Like, that's not the way it works.
No.
And I think just understanding that concept of like, it's finding ways to better handle your triggers. It's finding ways to better manage your symptoms, getting stronger, which I feel like is like the foundation of everything. Everybody strength train.
All of us?
Yes.
Yeah.
Yes, just do it.
Yeah.
If you're like, should I? Yes.
Yes, you should.
You should.
But yeah, it's not getting rid of all of them. It's trying to improve, yes, but we're never going to be asymptomatic completely.
Yeah.
Ever.
And on that note, to be clear, we are not saying that strength training is also that quick fix.
Yeah.
No, yeah, no, not that either.
Issues. But
No.
strength training is more important for your overall health and your long-term health.
Yes.
And the idea that you can't do that because of your hypermobility is putting your 80-year-old self in danger. And that's what we want to try to avoid. We know females specifically. One, I don't even think we talked about prevalence. So for hEDS, we now know that it is 1 in 500 people are being affected by this. Honestly, it's probably more, but that's what the documentation is saying.
Is that diagnosed?
That is diagnosed.
Okay.
And out of those, it's, I don't know the exact numbers, somewhere in the 90s% females. And so this is most commonly affecting females. We also know that females are the ones to have a lot higher risk for osteoporosis. We know that strength training can massively, massively reduce your risk of getting osteoporosis. And so by telling a mostly female population that they can't strength train, you are doing harm to that population, period. Stop doing that. Okay.
Yeah, totally. And I like couldn't agree with that more. Like, strength training has been the one thing. Like, if there is a cure-all, strength training has honestly been my cure-all, because it's the thing that gets rid of pain. It's the thing that gets blood flow to places that needs to be. It's the thing that makes me mentally strong, physically strong. And I think that anyone that's struggling with hypermobility, like, ditch the massages, ditch all these other things that like make you feel good temporarily. Go put in work with strength training, and I promise you that you will have long-term benefits. Like, I'm at like 8.5 months of pregnancy of not training like I wanted to, and I am still so strong compared to what I was prior to doing like body appropriate strength training too. And I think this is something I want to kind of point out. I think when you're hypermobile, you are different than the standard population, right? So like group fitness classes, you may not be able to keep up. Like skiing, like it would wipe me out. And I would talk to my husband. I'm like, how can you do like 9 or 10 runs? I'm exhausted after 2. And I would feel like I wouldn't have control over my skis or whatever it was. And I think you're just different. It's not better, it's not worse. You're just different. And unfortunately, the fitness community, along with all other modalities, doesn't understand your body. So pushing harder and getting the full workout in always, and, doing all the like standard like fitnessy things. Amber's really good at not doing that. But a lot of personal trainers out there and fitness instructors, and I worked in the industry for many, many years in the group fitness world, and it's scary. They don't understand that pushing yourself, getting that workout in, doing more, and trying to compare yourself to normally mobile. What's the word?
Normally mobile.
Normally mobile.
There's
Or even hypomobile.
Opposite.
Yeah, or even hypomobile people that might need to work on their mobility. Like, you're very different. It's not better or worse. So you have to allow yourself to modify, to change, to do whatever it is. And I think working with you and just hearing that can be really, really helpful, especially coming from an athlete mentality. And this is something that Amber's like still encouraging me to break with pregnancy of I didn't even realize that I had that athlete mentality of like push, 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 hard, hard, hard. And I just think that's just something that I really want women listening. If you think you might be hypermobile, or if you're postpartum or pregnant or whatever it is, like, you don't always have to do an hour-long workout. You don't have to get in the gym 5 times a week. Like, it's okay if you cut your workout short. And this is something I'm still learning to do. And I think that's really helpful and really like life-changing. It's not that all or nothing. And it's just like allowing you to meet your body where it's at, and it's okay.
I probably have the all or nothing conversation like 50
Yeah.
times a day.
Same.
Probably you
And
too.
yeah, like 100%. And in this population, there are some real physiological changes that make working out harder.
Yeah.
We take longer to build muscle. We take longer to recover. Wound healing takes longer because of our connective tissue. And so when you're comparing yourself to your peers, that's actually one of the things that I look out for in kids is if they're in a sport and they are trying just as hard as their friends, but the skills are just not coming to them and they're just maybe labeled as like not athletic or clumsy. Those would all be like little yellow flags to me that, okay, maybe we need to look into some other things here because those things are harder in this population. And so the worst thing you could do is go to a workout class and beat yourself up for not keeping up with the person in front of you. You're so much better off learning to listen to your body and give your body what it's asking for. And if people could start seeing that as just as big of an accomplishment as getting their workout done, that's where the real magic happens. That's where the real true progress comes from. And keeping their expectations for timeline longer. Those are like the two things I think that this population really, really struggles with.
And I think honoring the small wins.
Yeah.
100%.
Like, you can't
Always.
just like wait for the six pack. You know, that may be many, many years down the road or not coming. Like, you have to
Not
like
coming. Yeah.
or look at like, man, I was able to increase 2.5 pounds. That's huge. Or I did this without a flare. Or, I had good energy. I didn't need a nap after this workout, whatever it might be.
Yeah.
And I think that's really, really huge for both of your guys' populations.
I think it comes with a lot of retraining though.
Yeah,
and like
totally.
breaking a lot of these ideologies that we've had for so long that you need to look a certain way, that a workout needs to be a certain length, you have to be sweaty. I mean, I don't know how many times clients must be like, Amber, I wasn't sweaty, my muscles were on fire. And I'm like,
Good.
Educate.
That's the point.
Yeah. Or, well, I didn't burn a certain amount of calories. I've had clients like take their watches off and I'm like, please stop using your Apple Watch.
I
Please
literally
stop tracking it.
I hate devices.
Yes, because I think
hate
it
them.
gets so inside, it gets in people's heads.
Yeah.
Well, I didn't work out the whole thing. I'll tell clients too. I'm like, I would much rather you hit start on your workout, get the warm up done. If that's all you have the capacity for, or your baby wakes up, or you've been up all night and you don't have the energy, do 10 to 15 minutes. And as cheesy as it sounds, no matter what population you're in, if you get in any form of movement, celebrate that time you got in instead of beating yourself up for what you didn't get in. Because I always tell clients, I use the example of like stacking blocks, like playing with a toddler. All of us want to build the tower, and then like my 2-year-old, they want to knock it down when they quote unquote fail. Versus I'm like, just keep stacking the blocks. One stack every day over time is going to get you way better results than just knocking it down every time with the whole
Right.
all or nothing thing. But we have to retrain our brains.
Yeah.
Literally have to retrain our brains.
I make a lot of my clients write in big letters somewhere they see it every day, something over nothing 100% of the time.
Yes.
And every time you do that, you have to celebrate it, even if it's as simple as you just telling me or posting it on social media, because your brain remembers that. It holds on to those things. And the only way they're going to keep happening is if you recognize them.
Yeah. I love that. All right. we've already hinted at it a little bit, but women struggle with hypermobility more frequently than men. I think you said 90% of the hypermobile population is women. Can you talk about why that is and what's going on there and all of that jazz? Because I also think a lot of people think, oh, well, yeah, you're a woman, you're more mobile.
Yeah, so there is some truth in that. Women
Yeah.
are naturally bendier than males.
Yeah.
But as far as the symptomatic piece, it's not even necessary. Well, actually, both are true. Women are just naturally bendier, but there are men that are super bendy but are asymptomatic. And what we have learned is that testosterone is a protective mechanism
Oh.
for these conditions. And
Mhm.
they haven't really done a study on this, but it's like not peer reviewed, but there was a study with women transitioning to men who were hypermobile. And so they were taking testosterone at very, very high amounts, and their symptoms drastically
Oh,
improved
interesting.
across the board, which is like a very rare thing. It was a very small
Interesting.
sample size. Like we cannot extrapolate from it, but it is interesting.
Yeah.
And so we do know there is a component that our lack of testosterone makes us kind of more symptomatic. So that's one part of it. The other part is all the other hormones. So estrogen makes us more loosey-goosey. Progesterone also makes us more loosey-goosey. This is also why cyclically we can have more symptoms.
Mm-hmm.
That's not even including the mast cell component, which mast cells they live in your connective tissue, and there's a common comorbidity called mast cell activation syndrome that can come along with this condition, and estrogen and histamine and a lot of other chemicals share a lot of things, and so they affect one another. And so a big component of our symptoms being worse during times comes from our mast cells as well.
Which plays into like pregnancy postpartum too.
Yeah. Yeah.
Okay. For hormone fluctuations throughout the cycle, when do you typically see that for hypermobile symptoms like joint stability, pain symptoms? Is that ovulation? Is that period? Is that after your period? Like, when do you typically see it? I imagine it probably changes per woman.
Yeah, I was gonna say, I hate that we generalize
Yeah.
cycles in general. I am a big anti, what is it called? Syncing your workouts.
Cycle
Cycle
syncing.
syncing.
Yeah, I hate that because we're all different. We're all individual. I will say on average, it's usually either right before your period, during your period, or during ovulation. It's one of those three most often, not always.
Yeah.
And I have noticed that when it is ovulation, that subgroup usually does really, really well with different therapies that bring estrogen down. Whereas when it's more so during your period or right before your period, doing things to bring your progesterone down helps that population better.
Progesterone down or up?
Up. Sorry.
Okay. I was like, most of the time we don't want to do anything that brings progesterone down. Yeah.
Progesterone up, like progesterone creams, etc.
Yeah.
And tracking and figuring out your individual patterns is what I recommend to figure out what's going to help you the most for those specific symptoms.
Yeah. We'll have to do, Amber, I don't think we have a plan for season 2, maybe season 3, like an actual like menstrual cycle episode where I can kind of explain some of those things a little bit more for ladies, because I think for me personally, a lot of my MCAS symptoms, which MCAS has gone away during pregnancy, which has been great. Like joint stability has, I would say, certain joints have gotten more unstable with pregnancy, but MCAS stuff has mellowed out, and we've started using progesterones for some of our MCAS clients in the right way. Please do not just go get progesterone if you're listening to this. Please don't. But my MCAS and like joint instability flares typically happen on cycle day 4 or 5, right after my period. But I also ovulate very, very quickly. So my body basically went from like low hormones to like ramping up hormones pretty quickly. And so for me, that's where mine was. That's also when I got headaches and all sorts of things as well. And so, yeah, there's a lot that you can do to help support your body with detoxing estrogen, with raising progesterone. It's all connected. And I think that there is a lot of relief that you can find through things. So just if that's on your mind when you're listening to this, it's just important to know that there's a lot that you can do. Hormonal birth control, I think you and I have well, it'll be interesting. Like, I think we might have slightly different opinions on this. I know
Yeah.
that you'll recommend birth control for certain things to help bridge the gap for pain relief.
Yeah.
My perspective is typically try to avoid birth control as much as we can, do as much as we can naturally first. And then if it's still significantly affecting your life, then maybe birth control is the next option. But can you talk about like hormonal birth control for connective tissue for hypermobile folks?
Yeah, so I want to be clear that there is a time and a place to use hormonal birth control, and that is a privilege that we get to do that to prevent pregnancy. And I don't think we should take that lightly, because there is a time before us that they didn't have that option, and we do. That being said, we know that birth control, hormonal birth control, is not the best thing for our health.
Yeah.
And so two things can be true at the same time. You can use birth control and have no guilt, shame around it for whatever you want to use it.
Sure.
And it might negatively affect your health. Those two things can be true.
Yeah.
And so as far as the health side of it goes, I am on the same page as you. Let's try other things first. And if absolutely nothing is working, okay, let's potentially bring in a birth control. And if we're going to bring in a birth control, I actually usually recommend an IUD first, because it is more localized. Yeah.
That's also like a conversation that needs to be had, I feel like, in like the hormonal birth control community, because it's not actually like there's no way to actually only localize hormones. The other thing that I'm curious about, and if you've had this with people, my IUD got displaced, and then it actually allowed for pregnancy, had a miscarriage, stuff like that. And I'm curious if that has to do with connective tissue in my uterus, blah, blah, blah.
I've looked into this deeply. Yeah.
So you have. Okay. So will you talk about that a little bit?
Yeah. So there's no data on anything that I'm about.
Of course.
There's never going to be.
You've worked with so many people at this point. Like you have.
So this is all anecdotal.
Yes.
I've worked with over, 300 people in this community now. So maybe I'll do a study on it one day.
There you go.
And I've looked at my data sets, and I've really looked into this, and it is so variable. It's actually crazy. Like, there has been zero trends that I have seen. Okay. I personally had an IUD, and I had no issues at all. And I had a client who had an IUD, and she hemorrhaged in her shower because it got displaced in her own home, and it was a disaster. And so what I actually started looking, because it was so all over the place, was, are there common things for the people that it works well for versus the people it doesn't work well for? And the biggest commonality was some sort of hip dysplasia or hip specific anatomy changes. And hip dysplasia is a very, very common comorbidity in this population, or some sort of pelvic floor prolapse, etc. issue. They seem to not do as well with the IUDs as the percentage of the population that doesn't have hip pelvic floor specific issues. Again, this is anecdotal. Do not not sue me for this.
This is not medical advice. Can you explain hip dysplasia really quick?
So hip dysplasia is extremely underdiagnosed, and we were taught in chiro school it only happens in kids. It doesn't. There's a lot of adults with hip dysplasia, but it is your hip socket is too shallow, and because of that, your hip is placed in a not great position, and it can make certain movements really, really hard, and it makes your hips really, really painful. And the type of pain is very hard for practitioners to understand and diagnose, and a lot of the time it gets misdiagnosed as pelvic floor issues, or misdiagnosed as just period pain when it's not.
Interesting. Okay. Because I have very, very mobile hips. So then I was like, well, is it hip dysplasia? But I don't think so. But I'm kind of curious. I do have, Amber, like there's a study, or I don't really know if it's a study or not, but my pelvic floor PT said that there was like some study done on women where basically they found that 50% of the women had like a grade 1 prolapse and 50% had like a 0 or something like that. Are you talking about in the population? Like it could be normal.
Are you talking about in the population that's had babies, or just in general?
I think in general.
Okay, because there's a bunch that have come out now on like pregnancy or postpartum, I guess I should say. the average, don't quote me specifics, it's like 1 in 3 that have had a
Okay.
vaginal birth have some degree of prolapse, but only
Okay.
12 to 13% of those women actually are symptomatic.
Okay.
So many, many women have prolapse, but have no idea because they're asymptomatic. And so until this is where, again, we talk about like labeling.
Yeah.
This is where a label can be good, but also bad. So like a client can go in and have no symptoms at all. And I see this
Yeah.
all the time. Go into a PT or a doctor that are just trying to do their job. I'm not blaming them by any means, but they diagnose a client with grade 1, grade 2 prolapse. And the client's like, oh my God, that's the most terrifying thing I've ever heard. And all of a sudden, they're symptomatic.
Yeah.
And they were never symptomatic before the diagnosis. And so, yes, a lot of people have prolapse that have no idea they have prolapse. And I think a lot of this comes back to we
That's
just
true
educate
for
people.
a lot of conditions.
Yes, a lot.
Discriminations,
Yes.
exact same thing. That it's a big, big problem.
And it comes down to fear mongering. Like totally comes. I mean, I just had a client today like message me thinking she has prolapse, and I'm like, you probably do.
Yeah.
And like, it's not a bad thing. You're also super early postpartum, so like stuff can change substantially. But like, we're not taught how common it is or how many women actually have it without being symptomatic, and all we hear is prolapse, and it's just really scary, just like any other diagnosis.
There's a term for that. It's called iatrogenic diagnoses, and it's when a practitioner, with their words, not intentionally, but causes harm. And it's, in my opinion, the number one issue in chiropractic specifically. It's it's a really big problem. Be careful with your words. Your words matter.
I mean, I've had Johanna and I have talked about this, speaking of chiropractic. I've had 2 clients now, both go in for just like a routine chiro exam, be told one leg's shorter than the other, they need a shoe lift, blah, 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 and they get it.
Taylor cringing.
And then all of a sudden their hip hurts and their back hurts and all of these things. And I'm like, was your hip bugging you before? And they're like, no. And I'm like, then why does it freaking matter? Like,
literally.
But again, it's like this.
If we're going to get into that conversation, we need a lot more time, okay?
We could go down a deep, dark rabbit hole really fast, friends. Anyways, back on subject. But anyway.
Yes.
That's the prolapse stuff, Johanna.
I think what I was wanting to like get at is it seems like if you take the entire population of women, 50% may not have any prolapse and 50% might have like a very slight amount of prolapse, and both are normal and it's totally fine. And then I think, correct me if I'm wrong, it's like pretty much like after vaginal childbirth, you will have it and then it will slowly, hopefully get better. And then maybe it's 1 in 3, like continue to have it or not.
I think it's hard too because again, we're using like a grading scale, and it's like
Yeah,
how one doctor may grade is gonna be like slightly different. I think if this is like dilation, like we go check dilation and effacement. Well, everyone's hands are different sizes. So like it's not a perfect science. But yes, the pelvic floor post-birth, if you even if you don't have a vaginal birth, like just pregnancy alone is gonna cause some fatigue in those muscles. It's going to cause some physiological changes. So to go in and diagnose someone early postpartum, I really think is doing a massive disservice and causing a lot more fear that doesn't need to be there. If you're continuing to have symptoms well beyond 100%, I am always going to recommend a client go see a professional. But I think we need to educate better on what prolapse is, what the symptoms are. You're going to have some degree of it early on. It's the same concept with like diastasis, which is, similar conversation. So anyway.
For sure. Okay. I think we should probably start wrapping it up. Otherwise, we'll be talking.
We could talk for days.
So I think let's end it. Taylor, if you just want to throw out some practical tips, and if for ladies listening, if you think that you're hypermobile, like what would be the next great steps? Obviously, I recommend working with you, but next great steps, daily tools that they could start implementing, or even just paying attention to, or how to communicate these things, and what would be like your guidance?
I would say number 1, don't downplay and gaslight yourself. If you're experiencing symptoms, you deserve help. Number 2, strength train. I think we made our point there. But if you are struggling to strength train, know that there are ways to make that accessible for yourself. You just need to find the right approach. Number 3, extend your timelines that you're giving to yourself and get out of that all or nothing mindset, because it's not going to serve you. Number 4, that symptoms and flares are never going to be 0. Our goal is to decrease the intensity and frequency of these. Number 5, you don't need a label to get help, but if you want a label for your own validation, there is a process. Just be aware it's going to cost you time and it's going to cost you money. That is your choice though. And so make that choice, make the choice that's right for yourself in that terms. And then lastly, for clinicians, start learning about this disorder. You are seeing it. 1 in 500, probably more, are being affected. And especially if you are a chiropractor, we are the number 2 sought out clinician for this. We need to know how to work with this population. Number 1 is massage therapists.
I was just going to ask, what's number 1?
Yeah.
Okay.
So number 1 is massage therapists. Number 2 is chiropractors. We need to know. You are seeing this in your office, whether you realize it or not. And I'm going to give a self plug here. I do have a clinician course. It is approved for CEUs officially. I have not announced this yet. So this is it for 12 asynchronous hours for chiropractors, PTs, or OTs. And more importantly than that, though, is you need to know how to work with this population. You are doing a disservice to your patients and you are creating true harm in the world by not. And I truly believe that.
Yeah. Yeah, I was going to kind of follow up of if there's anything that you want to encourage for providers, but you kind of nailed it. But is there anything else? Just because we do have a decent amount of providers like mental health, massage therapists, chiropractors, and naturopaths that listen to this, midwives as well. And so if there's anything else that like resources, like I know you have a podcast as well, if there's anything that you would just love to say to providers that hopefully are now interested in learning more about this, knowing that like it is a huge part of the population.
Yeah.
So
my website, thehypermobilechiro.com, under resources, I have a resource page. That's a really, really good place to start. And then I also have my podcasts on there. That's also a great place to learn. The EDS Society is a good place for practitioners to go and get information as well. There are a lot of resources in general on my website, but the biggest thing I would want any healthcare provider to know or to start watching out for, if you see something and you're like, this seems weird, this is different than what I usually see, dig a little bit deeper and learn the very basics of the common symptoms in this population. And when you get that little yellow flag, just ask some of those questions. And if they're dealing with those, then go about the process, and don't be afraid to say, I don't know what to do with this, but I'm going to find somebody that does. Yeah. There is nothing wrong with doing that. That's so much better than pretending like you're going to be able to help this person that you're not going to be able to help.
Yeah,
absolutely.
Sure. And I think I'd also add to, like, for providers listening, like, question your education. And just because someone's not fitting the mold of what your education told you, remember that the education is very dated. I mean, like, that's the same thing with nutrition. It's a huge issue. Like, all of our medical doctors get like 1 lecture, maybe 2 lectures on nutrition. And it's like, it's not necessarily their fault, but now they can know better. So do better and start questioning things and take it upon yourself to start, helping a population that does severely need help. Because I imagine that 1 in 500 will hopefully significantly change over these like next, 10 years or so, and get maybe not diagnosed, but recognized a lot more, because it's like, I'm not in that. And there's a lot of people in my family that I think are hypermobile, like they're not in that. So I imagine that the number is probably way more significant.
Yeah. And just to put it in perspective, 3 years ago when I first started, it was 1 in 5,000. So in 3 years, it went from 1 in 5,000 to 1 in 500. And in 2026, the EDS Society is on an initiative to redo the clinical diagnostic process, which means everything's going to change. And so the things in this world are constantly changing. We have to stay up on the literature. Courtney Jessimer from the Norris Lab has a Substack. If you do anything, join that, because she is pumping out the research and updating the community day in and day out, and is doing a great job at doing that. And just, learn.
Cool. Do you mind sending us a link for that Substack and then put in our show notes for people that want to learn about it? Okay. Well, thank you so much, Taylor. Amber, is there anything else that you have questions on or anything?
No, just go follow Taylor. If you don't already, we'll put all of her info in the show notes. Go follow. Yeah. And just be an advocate for yourself, guys. I feel like that's the biggest thing across the board for everybody. So appreciate you coming, Taylor.
Yeah. Thanks for having us. Awesome. Thank you.
Thanks, guys.
That's a wrap on today's episode. Thank you for hanging out with us on the Wild and Fierce podcast. If you loved this conversation, we'd be so grateful if you left a review and shared it with a friend who needs to hear this.
And if you really loved it, take a screenshot, share it on your stories, and tag us. We'd love to see it. Until next time, stay wild, stay fierce, and keep owning your journey.